I'm Scott Reid. My wife and I, we grew up here, and so we knew we wanted to raise our family here and practice here. We're very fortunate to be back in Tulsa, and I'm in my 7th year back. And I had a fairly extensive sports medicine background when I was in the Army, and then I went and did the Adult Reconstruction Fellowship in Boston, and so now I'm probably 80 to 85% joint replacement. I still do a little bit of sports medicine stuff. So that look on my face there, I was saying I like to spend time in the mountains hiking around, and that's a pretty consistent, oxygen grab that I will commonly have when I'm up there. So a little bit of anatomy in the hip. So this topic was about, am I a candidate for hip replacement? So what constitutes people getting a hip replacement? And there's a host of pathologies that can lead to the arthritic pathologies, labral pathologies that will ultimately get someone into the hip replacement category. And they can come from different places. And a lot of times patients show up in our office and they'll say, my hip hurts. And they will generally point to some region, front, side, posterior, SI joint, lumbar spine. Classic hip socket pathology generally is groin pain. So if someone says, I hurt, deep into my groin, it hurts with rotation or pivoting on that hip, or I can't bend over and tie my shoes, those are the things that, will sort of hone us in to the hip socket. And so the acetabulum is the term we use, for the socket. The femoral head is the term we use for the ball. And these aren't, those aren't commonly used terms with our patients. And so we usually just say socket and ball. But then there's a host of muscular anatomy around the hip as well. And so these are the posterior structures. We've been reflected, the gluteus medius, which is interestingly probably the most important muscle around our hip. When it comes time to talk about hip replacement, that's sort of our main stabilizing muscle for the hip socket. And we'll see patients who have a deficient gluteus medius, and they can have real problems in the setting of a hip replacement, and even without. One of the things that I kind of focus on with my patients is how we do hip replacement. So I'll answer the question of what gets people to my office, and then we'll go into how we go about treating that. So if someone is having long-standing pain that's not going away with physical therapy, anti-inflammatories, and activity modification, generally for greater than about 3 months, we've tried perhaps an intra-articular hip injection with them. They show up, they've got x-ray changes consistent with an arthritic nature. If they don't have arthritic changes on their x-ray, I may perform an intra-articular hip injection with them, asking them to give me an idea of how much pain relief they get for the first 30 minutes to an hour, because that's local anesthetic effect. And if we numb up their hip socket and all their pain goes away, then they probably are experiencing some level of labral tear and or chondromalacia. So if that is a very positive response for them, but they don't get lasting relief, then we may get to the hip replacement talk. So I show the musculature around the hip just to give people an idea of how crowded it is. There's a lot of stuff going on there. So hip replacement. This was pioneered by a guy out of England. His name was John Charnley, and he actually got knighted. This is a picture of one of his old hips. And when I was first in training in the early 2000s, we'd still see some of these Charnley hips out there. It was basically a piece of plastic cemented into the pelvis, and then this sort of monoblock prosthesis that got cemented down into the femur. And if they were done well, they'd last 20, 30 years, which is really pretty impressive considering these people oftentimes, they were doing this with relatively limited technology, which we have we're light years ahead of that now. So a bunch of different approaches. The Charnley approach was somewhat anterolateral. They would actually cut the greater troch, perform an osteotomy, and then fix those back. The anterolateral approach, again, a troch osteotomy. So if you're having to take that greater trochanter off, let me go back and I'll see if I can point out the greater trach. So can you guys see my cursor? So the greater trach is right here, and that's where that gluteus medius attaches. So if we osteotomize that thing, and I've got this muscle, I got to fix it back down because that medius is going to be a big deforming force. So you can see that, that's problematic. So as time went on, the direct lateral approach came about. The problem with that is that you were going to split some of your muscles, and then the posterolateral approach sort of became the workhorse of 90% of the hip replacements that got done in my fellowship were done through a posterior approach. Well, you're going to have to dissect a lot of those short external rotators off the back of the hip. It kind of got a bad reputation for dislocation, which the dislocation rate was quoted at about 2%. And that's where, anterior approach came about. Anterior approach was sort of advocated for late 80s, early 90s, and then into the 2000s. Industry got behind this and said, this is a way to do this. Let's make some money off of it. The problem with the anterior approach is it takes this medial contraption called a fracture table to dislocate the hip. And if you can see, if you look real close where my cursor is right here, this is a hydraulic lift that you put a hook in underneath the femur. You push on the little foot pedal, and it will literally hydraulically lift the femur into your wound. And so you can imagine not everybody's as flexible and not everybody's that thin. So the anterior approach, it's not really fit for everybody, okay? And that table costs about $100,000, so not everybody can buy one of those. So then if we wanted to try to have the most optimal approach for getting in and out of the hip, you want it to be reproducible. You need to be able to extend it in case you get into trouble. Let's say heaven forbid you fracture a femur while you're putting a stem in. You want to be able to extend it without causing undue trauma to the patient. No need for extra equipment like that $100,000 table. And then if we can account for potential challenges, and we'll get into Xpert here in a little bit, leg length and offset can be predicted, less pain, shorter stays in the hospital, lower costs. I mean, those are sort of our best cases scenario. So with a direct superior approach, and that's what I do, and I actually do what's called an in situ superior approach. And so we're going to come into the hip in a way where we actually don't take any muscle off of the femur. I do release the piriformis because most people's piriformis is really tight anyway. It also performs as it sort of serves as a soft retractor for our sciatic nerve. And about 1 in 1,000 people's sciatic nerve runs on the wrong side of the piriformis. So if you don't take it off, you can squeeze the sciatic nerve and cause an injury. So I do reflect the piriformis. You can do this surgery. I have patients go home same day routinely. We have a lower dislocation rate. I actually would argue that you have a lower dislocation rate than an anterior approach whenever you do the surgery this way. Patients tend to have minimal pain. They're up and moving. I've had patients do this with nothing but Tylenol post-operatively. Compared to more traditional hip replacement approaches, there's less blood loss because we're not dissecting as much muscle. And then I don't ever guarantee incision sizes because patients' body habitus has more to do with how big their skin incision would be. But I've done it through, I have a guy who's 6 feet 4 inches tall and weighs about 180 pounds, and his incision for his hip replacement is about the length of my index finger. So that is possible. And then the nice, I don't have to have a bunch of extra assistants in the operating room either, because the leg sits in a relatively comfortable position and nobody's having to hold it throughout the entire surgery. So just a little bit about technique. Patients laying lateral on a pegboard with their foot on a Mayo stand, which is essentially a little table we have in the operating room. 40 degrees internally rotated, 40 degrees flexed. It's about an 8 centimeter incision in most people. Again, I don't guarantee skin incision length. It goes in line with the fibers of the gluteus maximus. Once we make our incision, we take it down through the fascia of the max, and I'll put a finger underneath the medius, put a retractor under the medius. We reflect that piriformis. I don't generally take off the externus. The classic description of this technique does. And then we incise the capsule along the inter aspect of the piriformis, and we tag those slide retractors underneath it, and I'm looking at the top of the femur. And so compared to, this may be a video. Yeah, it is. So compared to more traditional approaches, I put my retractors in, I leave my retractors in. We prepare the femur. So here's our skin incision. We get down to the level of fascia. Fascia gets incised right in line with fibers of the gluteus maximus. Once we can expose the bursa over the medius, put retractors underneath, this is then reflecting the piriformis. We open the capsule. Now we have retractors front and back of the capsule. We're looking at the junction between femoral neck and femoral head. There's our capsulotomy. I was a little ahead of myself in my narration. I don't generally make the big T. I just do a straight incision. So then we open up the femoral canal, and so this is the difference between most other approaches. We've left the femoral head inside the socket while we're preparing the femur. Again, all in an attempt to keep all that muscle attached to the proximal part of the femur. So we dig a little trough in the femoral head neck junction, we work our broaches, we then have a saw blade that will come in and we use that broach as our guide. Put a little screw into the femoral head and we take the femoral head out. So we never had to change the leg position. I didn't have to dislocate the hip. All in all, it's less traumatic. Detractors to my approach will say, well, I can't see anything, and I think that that's short-sighted. I'm going to pause this for just a second. Short-sighted in the sense that if you're standing across the table from me, yeah, you can't see anything, and that's a good thing for the patient because that means that I didn't open the patient up so wide that everybody around the room can see inside their hip. But whenever you get used to performing the approach the way that we do, I think it's actually faster, it's easier, it's less blood loss, it's faster to close, less surgery time, and patients do better. So all in all, it's a win. So this is showing reaming the cup. We have to shape that horseshoe-shaped socket like a hemisphere. We put our socket in, we drop the ball, then we put a neck segment on the femur, and then we reduce the neck segment to the ball, which is a little bit different than some of the more traditional approaches. That picture right there is showing how much flexion and internal rotation a patient can have and still have their hip reduced. This is not a dislocated hip. If you were doing a posterior approach and you dislocated all that, dissected all that posterior musculature, your hip would be popping out right here. And so this is showing putting the final impacting the final liner, final head, final stem is in place. You put it back together, and then you close your wound. Okay, so let's go on to the next. So Hip Xpert is sort of an adjunct to hip replacement, and it doesn't really matter what approach you use to do the hip. If you're going to use Xpert, Xpert is just a way for you to navigate your positioning, know your sizes, offset, leg length changes that'll happen, depth of the stem and the femur. This is an optional software because most insurance companies, and I say most as in all, won't cover this. Insurance is an interesting thing in that we all pay our premiums, and then when it comes time to get surgery, most of the insurance companies, unless we've checked all these little boxes for them, they want to deny our request for surgery. And so whenever we try to ask for something extra like this, it's an uphill fight. So for the patients who choose to use Xpert, they can order this through Superior Surgical Planning Services. We buy the plans from a company that develops the software. And what this does is we do a CT scan ahead of time. We create this 3D model. And I don't know that I have in this video any of the 3D stuff where I can show you how we can rotate the pelvis. But we can see the pelvis in every angle. We can see where the bone spurs are going to be. And then we can position our implants in that model. So this next picture shows the green is a cup. The software will actually give us data when we move those cups and implants around. Once we get that data, we can transfer it to this device that you see here that we lovingly call the hip sextant, kind of like a sextant you've got a ship with back in the old maritime days. So once I have that set, I dock it onto the pelvis in a very specified manner, and it allows me to reenact what I've done in the computer. The benefits of this program are that it allows me to sort of have a second set of eyes. There's a new iteration of this called Hip Insight. Hip Insight actually uses Microsoft HoloLenses to project a hologram of the patient's pelvic anatomy into their body. So while we're doing the surgery, I can see where their bony anatomy is, and I have holographic images of where my cup is supposed to be, where my stem is supposed to be, where my cup impactor handle is supposed to be aligned in order to make sure that we've set things as accurately as possible. So the technology that we have now compared to, say, when Dr. Charnley was doing it is pretty impressive. So again, the bonuses to this: smaller surgery, more accurate component placement, less likelihood for a dislocation, and longer lasting components. Those are our goals. All right, so let me see if this one will play. Yeah, so this is basically the promo video from the company that makes this. I'm a big proponent of the use of this. It makes my job easier, and I have a video on our website where I basically make the comment that generally when something is better for the surgeon, it's better for the patient. That's not always true, but in this scenario, I think it's true. It's more information. Once we get our cup ready to put in, we dock the device down onto the pelvis, and then I've taken that data that we've got from before the surgery, and it allows me to reenact that plan in surgery. It kind of plays off of the idea that the human eye is able to catch parallel lines very accurately. And so we have these aiming guides, and then you end up aligning your aiming guides with your impaction handle. The newer, as I mentioned, the newer technology with Hip Insight is it's all holographic images. So you overlap your real life handle with your holographic image handle, and you perform your augmented reality surgery. So really a pretty neat time to be doing hip replacement. So, but this is just an example of how the system works. Okay. So benefits of the superior approach. It can be done virtually on any patient. Doesn't matter how big or small they are. Sometimes, you know, I've got colleagues that do an anterior approach. They won't do it on someone who's very large or has, you know, perhaps a bigger abdomen, because that incision is going to be up underneath, you know, their skin and make them more at risk for having a flexion contracture and or an infection, which would be worst case scenario. So we can do this on anybody, and I would argue that it's easier to do on a large patient than a posterior approach would be. So smaller soft tissue dissection, less pain, earlier return to function. I mean, these are all the things that the patients want. Dislocation extremely rare due to the preservation of those dynamic stabilizers. It's easy to convert into a traditional posterior approach if we had to. Heaven forbid, we've done a hip replacement on somebody and they go a couple weeks or years and they are in an automobile accident, or they trip and fall, the dog runs past them and they end up fracturing around their stem. I can use the same incision, just extend it distally, and I'm not compromising myself. Whereas trying to do that from an anterior approach is very difficult. No precautions post-operatively. So I don't put any range of motion restrictions on my patients after surgery. I do ask my female patients to use their walker for a couple weeks for physiologic reasons. You know, women tend to have a higher periprosthetic fracture rate than men, and I use press fit components, and so we try to protect them for that first couple of weeks. If they see us at their 2-week visit and they have a good looking x-ray, then we'll let them go ahead and progress to weight bearing as tolerated. And then again, no special tables or live x-ray are needed. So this is a guy I did just a couple of weeks apart. This is his post-op x-ray at the visit, the first post-op from his second hip. And this is him at that. He's 2 weeks out from one hip and he's like 5 weeks out from the other hip. And so, I mean, this is what's possible, you know, in hip replacement. And so, really pretty impressive, considering that when people come in, you know, they're really pretty hampered. They're inhibited by their hip pain. Some of them are even having trouble getting to the bathroom. And so, I appreciate you guys taking the time to sit and listen to me ramble, but I'd be happy to entertain questions here if you have any.
Yeah, that's awesome. Thank you. Thank you so much for putting this on. So I'm Josh. I actually work for Red Bud Physical Therapy. I'm up in Collinsville. So we get a lot of your patients, and I super appreciate that. The first thing I'm going to mention is, well, now it makes sense why you don't have any precautions, because that was one of the things that always kind of stumped me was, right, sweet, you know, we got somebody coming from Dr. Reid. This is great. They don't have any precautions, but I never fully understood why. I just knew that we didn't have any precautions, so the patient could do so much more earlier, which is great from a functional standpoint. You know, you keep them in for 6 to 8 visits, as opposed to a lot of traditional approaches. You're looking at 16 to 20 visits, right? And that's a big hit for a patient. So that's really cool. So it's nice to really know that. And so with so I've got a couple of questions if you're okay with that. So my first question would be, what with, especially with this, considering they're coming out so well, do you have any specific focuses that you would like us to make sure that we target whenever they're in an outpatient clinic besides just function?
Yeah, so I'm actually I'm a little bit coordinated physical therapy averse for the first 2 weeks.
Okay.
And so much of our traditional therapy, and the reason I'm in orthopedics is because I lived in the physical therapy shop as a high school athlete because I was always broken, right? So the therapist, I can do a perfect surgery and the patient do nothing and they turn out poorly. Whereas, I think our therapists guide the patients. You spend so much more time with the patient than I do that you really guide them through that post-operative process and get the ultimate, best results, which is that partnership is amazing. I mean, you guys, you can actually take a bad surgery and make a patient good. I mean, that's the truth.
Well,
but with hip, so much of what we do in there's this insult around the hip socket. The iliopsoas is so finicky that if we do a lot of repetitive leg lifts and or marching in place or trying to strengthen early, we can see a tendonitis that makes it real hard for patients to get away from. The other things that we'll see that are kind of perhaps a hip flexion contracture, and I think that's just by the nature of most of these people are going to sit more than they stand after these surgeries, and so when they sit with their hip, flexed anywhere from 60 to 90 degrees for 3/4 of the day, that musculature and hip capsule will scar in and heal in a shortened position. So the things that I ask for a very, very gentle anterior hip capsule stretch, iliopsoas stretch, once an hour, hold it for 30 to 60 seconds, and get up and down from a chair and walk. So for the first 2 weeks, that's really all I really want to see. If I see the patient back at the 2 weeks and they're complaining of IT band tightness, which, if I have to put some offset on somebody to give them best range of motion stability, a lot of times that IT band it'll be tight. So we'll focus on the IT band and then gait training. Because as you know, a lot of these folks have been walking with a Trendelenburg gait. For those who don't know what that is, it sounds counterintuitive, but people will end up sort of lurching over the side of the disease. Even though you think, I'm going to put all of my weight on that, you actually reduce the amount of muscular force that's driving the ball into the socket. And so instead of seeing 4 times your body weight trying to walk normal, you're only seeing 1 times body weight. So we have to sort of train patients out of that because they'll short step because of a tight anterior capsule, and then they'll still be wanting to lean over the side of the surgical hip. And so teaching them an appropriate gait is oftentimes, those are the big things for me.
No, that's fantastic. Thank you. And so with that, I'm really big on a lot of closed chain functional movement pattern stuff anyways. I personally am not a big fan of open chain movement patterns for the hip anyways, because they're not functional. And so with that, maybe some side lying, hip abductions, of course, for some glute med activation or some clams to get some glute activation for the most part. I like them upright. I agree with you. I don't want to inflict a tendonitis on somebody trying to do a traditional PT approach that's been around for 40 years that we can move past.
Yeah, you know how hard it is. That's the thing. And these patients would say, what's wrong with my hip replacement? Well, there's nothing wrong with your hip replacement, but the stuff that we left there is fired up. And so I love all that you're saying.
Perfect. Good. Well, that makes me feel better too, because the patients look at me like I'm crazy whenever I try to get them off the mat, because that's just what they've always known. And it's just like, no, this is what we need to do, because this is what your hip was designed to do. It's designed to move in this movement pattern. So that's great. That makes me feel like I'm on the right track for sure. And so if the only reason I ask this, because I currently have a patient that is looking at he's going to have ACL reconstruction. I know it's different than this, but the insurance is requiring us to do a prehab basically. And so the insurance like, we're not going to pay for the surgery until they do a month of rehab, right? And I know some insurances do require that. Blue Cross Blue Shield seems to be a big one. And so if that were to happen, would there be something, would it be on the same lines of what you just described that you would want us to do with this person? Would it be like, we need to get that anterior capsule stretched out, we got to do some Thomas stretching to free up the hip? I mean,
So you're hitting one of my least favorite subjects in that's this insurance authorization issue, because if you take a patient, and I can show you some x-rays of people that I saw today who have a completely collapsed femoral head and they've got large osteophytes, they essentially have a doorstop in their hip, and then insurance says, well, they need to do physical therapy before we do this. So some of the tenets, of physical therapy are to improve range of motion and restore mobility. Well, if I have a physical reason that I cannot take that socket, that joint through more range of motion, all we're doing something that the insurance company says we have to do.
Yeah.
And so we end up spending more money than we need to, and so I think there's some of those situations where there are going to be patients that the therapy is not going to benefit them all that much before the surgery. But then there are those that maybe they've still got some decent range of motion, but because of their pain, they've been very hesitant to exercise. They are perhaps feeling like, any activity is negative for them. And those are the ones that I think can benefit. There's a lot of studies that show that, especially knee arthritis, hips, as long as you don't pivot on them, if they can actually get some exercise, they'll feel better, right? We can reduce their pain, but I think there will be some that it's not going to help them. But from what we can do, I think you have to assess each patient and find out what kind of passive range of motion they have. Try not to push them too much further, in an arthritic hip beyond what their passive motion is, because you're probably hitting, osteophytes, and you could certainly cause them to have more pain.
Yeah, and I agree, and I hope that you're okay with this. I know each physician is going to be different, but I personally love to look at the X-ray as well, just to see if we've got some sort of like a pincer or cam impingement or some sort of a, like you said, a collapsing of the femoral head, right? Like the femoral head looks like a Lego. It doesn't look like a ball anymore. And so whenever I look at that, then I have that time to sit and reflect and say, okay, my job may be just trying to get this person to get a better gait pattern,
Right.
and better movement strategy. So that way, whenever they get out of surgery, they're going to have this known. Or I might spend more time doing education, rather than trying to, like you're saying, oh, you only have a 94 degrees of hip flexion, but you're supposed to have 120. So we're going to get that 120, right? It drives me nuts. And so with that,
some of the pre, if you know that you're kind of headed towards the surgery, you can almost use it as an educational experience, like you were saying, to say, after you get this fixed, these are going to be the things, these are going to be our goals. And then the patient maybe goes into the procedure and that post-operative period with a little less apprehension. They can feel a little bit more informed. And a lot of times, I'm a firm believer in forewarned is forearmed. If we know what we're getting into, then we have a better chance to have a successful outcome.
Yeah, and I agree. And I think that's one reason why I try to use that as some education time, just because they do have a lot of questions. And like you mentioned, I'm very fortunate. I get an hour with them. And so I can spend a lot of time just kind of discussing those things. And then if anything really scary comes up, that's whenever I call the doc and just say, hey, just so you know, Mrs. Smith is really worried about blank or whatever.
Yeah.
But I mean, I love the education aspect of it, because you're right. I do feel like they always do better afterwards because they knew what to expect.
Yeah, for sure.
So that's awesome. That makes me happy. I have my last question is, so if I've got somebody that's coming in, besides just writing your name down on a Post-it, which I often do and hope that they don't lose, what's the easiest way of like, hey, I'm going to have Mrs. Smith come see you. Can you look for her name, come across the screen on your schedule? I mean, is there a way that we can kind of have that connection, so that way I can get them to you better? Yeah.
No, so I truly appreciate that. I've got my assistant, her name is Paula, and she's got a phone that she will answer on Mondays, Tuesdays, and Thursdays.
Okay.
And then on Wednesdays all day, we're in clinic, so we're running around pretty crazy and don't get a whole lot of return phone calls on those days. And then on Fridays, we're in clinic in the morning, but she usually can answer those. So she's our standard number, 918-392-1541. That's
Okay.
probably the best way to get a patient directly to me. If you leave a message and say, hey, this is Josh up at Collinsville, and I've got this patient that I really want to get into Dr. Reid. I think she has whatever the problem might be, and it's needed to be seen quicker than, 2 months from now when my first available is, and she's really good about getting people in.
Nice. That's fantastic. And you said 1541 was the last four.
Yep.
Is that correct? Okay. Whenever I do make that call, are you okay if I use kind of the medical diagnostic terms if I feel like she might have an
100%.
impingement
She's
or?
had both. Yeah. No, she's had both her hips replaced, both her knees. She's a very educated person.
Okay, perfect. Well, I've had some fight back for you can't use those words because you're just a PT. And so I want to make sure it's not going to be offensive if I like, hey, I think this is what's going on. This is why I think she needs you.
We depend on y'all to help us with those things. So we're very thankful for that.
Fantastic. Okay, perfect. Well, that's all the questions I've got. So thank you so much for that information. That it makes so much more sense now. I knew they always did well.
I'll tell you what, I need to update these slides, and I wrote an article for Orthopedics Today several years ago, and we took so many photos that I could almost make a stop motion video out of the photos. But if you're to see, the animations they're pretty good, and they're good for the general public, but for more if you're in the healthcare world and you can see these images without, this was made for patients and the general public, but if you saw the images of the actual surgery, then you would really, really get an appreciation for the difference. If I show you side by side an anterior approach, posterior approach, and an in situ superior, you look at it and you go, okay, yeah, I really get it, because you can see all of that muscle still attached to the proximal femur. It's really pretty impressive.
That's fantastic. Is there a way to see that presentation, or do we just need to wait till next time you present?
I'd have to put it all together, yeah.
Okay, no worries.
Have me put it together.
I'm sure
no
we'll
stress.
get me to do another one of these things before too long.
Yeah.
No stress on that.
Thank you guys for joining us, Joshua and Kylie. It was nice to have a little audience, and thank you so much, Dr. Reid.
All right. Thank you.
I appreciate it. Take care.
Bye.